Hello and welcome to Yodo. I'm Dr. Sarah Bohm. Today I'm going to address the elephant in the room, pain. I'm going to give an overview of pain. This is an introduction and it's the first of many discussions we'll have on this very complex topic. For today, information about pain will help you understand the difficulties involved with the evaluation and treatment of pain. Terms used to describe pain, and some background information about how the same person can have many different types of pain, sometimes even when the pain is caused by the same issue. This topic opener will give you some of the communication that we use when we're talking about pain, and the next videos will expand even more on these basics. The evaluation of pain is convoluted, as there are several types and mechanisms of pain. The pathways seem to interlock and overlap. Pain is a feeling that a person has when something is wrong. Pain is real. Nearly all people feel it. Pain is difficult to quantify, as a person's pain can be very different from someone else's pain that's having the same problem. Pain is difficult to describe in its intensity and its character. Pain interpretation is affected by prior pain experiences, as pain is unique to every person. The pain threshold is when pain has become great enough that the person becomes aware of it. Pain tolerance is different for different pains and varies person to person. Pain sensitization, intense, repeated, or prolonged stimulation that continues to affect damaged or inflamed tissue, that actual threshold is lowered over time with increasing firing frequency being elevated. Have you ever heard of the phrase, burr under my saddle? So there's just a sore spot, and every time you touch it, you don't have to touch it very much for that sore spot to really tell you it's still hurting. Common patient questions about pain are going to include, what is causing this pain? Why won't the pain go away? Is this going to get worse? What tests do I need to find out what's wrong? What is the strongest painkiller I can take? What doctor can get rid of this pain, or do they need to cut something out? What are the side effects of the medication that I'm taking? What else is this medication going to do to me? Could I get addicted to this medication? So there are a lot of thoughts that race through a person's mind when they're having pain that escalates and doesn't go away. Your doctor has as many questions as you do and will counter your questions with questions of their own. They're going to want to learn about the type of pain. Is this acute? Is this chronic? Is it neuropathic? Is it nociceptive? Is it radicular? And to gather their information, they're going to give you a long list of questions that you're going to have to answer. And so it'll take a little bit of back and forth communication for you to tell your physician about your pain. Starting questions are going to include topics around the onset, its location, its duration, the intensity and severity of the pain, what modifying factors do you have, what makes it better, what makes it worse, what's the pattern of pain? Does it occur at a certain time of day? Is it better at a certain time? Does it wake you during the night? And is there radiation of the pain, or does it just stay localized? The answers to those questions are going to lead the professional to some other questions, and then the tests will need to be done. The responses to pain are many. There are physiologic effects that occur to your body because of pain. Respiratory changes include increased rate of respiration, possibly decrease in volume, and possibly a decrease in cough reflex, or cough force can actually go down. The depth of your cough can be decreased because of pain. It can actually increase the risk of having a lung infection. There are cardiovascular reactions that occur. Your heart rate goes up, your blood pressure can go up, and you can have an increased risk for cardiac ischemia if you've got a cardiac problem. There are repercussions on the smooth muscle, the muscle inside of your body that you don't have control over, and that can cause changes in your gut and your GI system. You can have increased secretions, decreased motility, and increased in sphincter tone. And it can also affect the smooth muscle in your genitourinary system. So you can retain urine and you can have a tighter urinary sphincter so that you're not able to get your bladder completely emptied. There are common ramifications to the neuroendocrine system, and that's the hormone system of your body, and it's a very intricate and complicated network. There are an increase in catabolic hormones, decrease in the amount of insulin, so you've got more blood sugar in your body, possibly decrease in the amount of testosterone, but there can be an increase in muscle and protein catabolism to give you more energy. Pain can mess with your immune system as well. As your immune system becomes dysfunctional, you become more at risk for infections. And many people can be surprised to learn that even our blood clotting system can be affected. The ability for proper and timely coagulation can be changed with altered clot formation occurring. So pain is affecting many things, and it for sure affects our behavior. Some become self-absorbed or withdrawn. Many may have an increase in fear and can feel an increase in their alertness and startle with a sense of increased anxiety. Others might find an increase in depression, possibly even despondency or apathy. And many will express a sense of edginess or anger or hostility. I've had concussions from my days of Wild West horseback riding and rodeo experiences, and I openly admit that if I get a blow to the head, I experience irrational rage. And I've told myself that this immediate fury is some weird effect from those old injuries. At least I hope that's what it is. This is a good segue into clinical pain. This can be divided into two classifications, somatic and visceral. To keep with the theme of keeping all these things complicated, these two classes have a lot of overlap, so it's not going to be simple for this either. There is somatic pain, which is more, think of the skin and subcutaneous tissues of your body. It's deeper sensations can be involved, bones, muscles, soft tissue, as well as the skin. Ischemic pain can occur, spasm pain, and even pain from infection. So like if you get a wound on your arm and it becomes infected. Visceral pain is more internal organ pain. It's typically poorly localized and it's very difficult to pinpoint. Think about symptoms such as nausea and vomiting, where your gut may be distended or your bowels may be bothering you. You can have guarding. It could be from ischemia or inflammation of your internal organs. Keep in mind that inflammation pain is not the same as neuropathic pain. So you see how complicated this gets and how quickly. The types of pain could be nociceptive or neuropathic, and each of these has subtypes. Some sources also add allopathy into these types of pain. But this is a continuum of pain from the acute, adaptive, and expected pain to when pain becomes more chronic, maladaptive, and more centralized. And this is an explanation of the processes that change when pain lasts beyond 6 to 12 weeks. For some, it could be a shorter period of time to move from acute to chronic pain. And for others, due to a combination of multiple contributing factors, they may be not as likely to develop chronic pain syndrome until they've had that pain experience much longer, past 3 months, maybe even past 6 months, before that acute pain starts taking on characteristics of a chronic pain pattern. Back to nociceptive. It is mostly sharp or aching or throbbing, and it's typically due to an acute injury. The acute injury pain, like think of a sunburn or a cut, a sprain, or a fracture. So circling back, somatic pain is of the extremities, the skin, and muscles. It's more mechanical in that something has been injured. Your visceral pain also may be an injury, but it's more inside of your body. Think of like a kidney stone, a gallstone, maybe cardiac pain or stomach pain. But the organ or possibly the skin over that organ is getting stretched or something is pressing on it, whether it's a bruise or a stone. Neuropathic pain typically is from a disease process that has affected the nerves. Some process has caused that nerve to be damaged, whether it's shingles or maybe diabetic changes have caused sensation changes. That's a really common process. But could include something like a vitamin B12 deficiency can cause those types of pain. Effects from heavy alcohol use over many years. Poor blood supply, and for sure damage to a nerve, such as from a disc problem or trauma or even a surgery. Also in the neuropathic pain class, we would include things like somebody who's had a stroke in the past, someone with Parkinson's disease, a person with multiple sclerosis. These individuals also have considerable pain that is difficult to treat and difficult to explain, and it's typically neuropathic pain. Let's get back to those pain questions. Some pains are referred and radiating, and these could be visceral pains or neuropathic pains. The pain might involve specific dermatomes. So think of cardiac pain where it involves the level of your heart, so it could go to the neck or the jaw, your shoulder, possibly into the back or shoulder blades, and it might feel like they'll describe it as feeling like they've got indigestion. Stones that cause pain might cause this kind of referred or radiating pain, such as a kidney stone may cause radiating pain around the body, from the flank and even down into the front of their body or into their groin or sometimes in their upper thigh area. When we consider pain, character, and intensity, we're asking about the physical sensation of hurt that is being caused. Pain is a warning bell from the brain and body to tell a person that something's not the way that it should be. Common descriptors of pain typically will include, the physician's going to ask anyway, is it sharp or dull? What about being achy, shooting, stabbing, throbbing, or cramping? Are there sensations of burning, or is there numbness and tingling? And you're not going to pick all of those. Each of the descriptors leads the path in a different way for the evaluation to occur. So it's not typically going to be all types of those pains, and that does help the clinician determine the cause of your pain. There's a difference between the inside and the outside of our body because of the type of cells inside our body and the outside of our body are very different, and the information that they receive and send to our brain is also very different. So when something's not right, that sends that signal. Our skin, especially hands and face, can detect many things. If you hold out your finger with your eyes closed, you can tell if it's warm or cold, wet or dry, rough or smooth, silky or sandy, sharp or dull. And on our fingertips, we have 2-point pin discrimination to 2 millimeters. As impressive as that is, our tongue has 1 millimeter 2-point pin discrimination. So the outside of our body can give us a lot of detailed information. The inside of our body doesn't have that same kind of nerve going to it, and so it doesn't give us that same amount of information. When your physician evaluates your pain, there are 7 core aspects that are being evaluated to complete this and addressing the pain dimension: physical, sensory, behavioral, sociocultural, cognitive, and the spiritual aspect. So to evaluate a person and address this pain, we have to consider each of those dimensions as well as that form of pain. Some types of pain are temporary and others may become lifelong. Acute pain, typically less than 6 weeks but could be up to 6 months in nature, can sometimes be a little bit more different to treat than someone that develops chronic pain, which is typically pain that's longer than 3 to 6 months. Then it becomes a little bit more different in the pattern of how the physician has to treat that pain. A common approach to pain addresses 5 key concepts: analgesia and relief. What is the pain level of the patient and how do we achieve relief of that? Activities of daily living, and what's the function of the person? Are they able to still perform and have daily joys? What are the adverse effects of the pain and the medication that's being used? What are the risks involved with that? What's the affect of the person? How is their mood doing? What's their sleep like? As well as with medication use, we need ongoing monitoring for any aberrant drug-related behaviors, especially if opioids are being used. Let's talk a little bit about the 1 to 10 pain scale. Honestly, I'm not a big fan of it, but we have to have some way to quantify that pain. So for many reasons, mostly because in my career, I've had a lot of times when patients have told me that their pain goes to 11 or 12 or 50, even when the pain scale, the numbers only go from 1 to 10. Briefly, what's supposed to happen is the patient is supposed to give us a number between 1 and 10 to illustrate their pain number. 0 is no pain at all. 1 is pain that is so minimal the patient doesn't really remember it most of the time. 2 is an annoying pain. It's minor, but it is noticeable. 3 is more noticeable pain, and you're really not able to ignore it, but you can continue to move along. 4 is moderate pain, 5 being moderately strong. 6, the pain becomes strong enough to interfere with your activities. 7 is very strong pain and can limit your activities of daily living and the things that you just do in your own home. 8 is more intense pain and it interferes with your ability to even think. It interferes with your thoughts. 9 is pain so severe it prevents your speech, and 10 is the worst pain imaginable. Common behaviors that are seen with pain: crying, grimacing, rubbing, guarding, and immobilization of that body area. When greeted by the unwelcome guest of pain, most of us turn first to easy, accessible, non-pharmacological treatments such as heat or ice, massage or pressure. You can even get a TENS unit now at like local pharmacies. Distraction, relaxation, or meditation, guided imagery can help, and hypnosis certainly can help people with pain management. Then we'll move on to medications that we access from over-the-counter supply, such as Tylenol or possibly Advil or Aleve. When we see our doctor, medication classes will advance, and they'll use more powerful anti-inflammatory medications, anesthetics, possibly anticonvulsants, or some antidepressants can also interfere with the pain signal, and then certainly opioids. So the back and forth dialogue of communication between the doctor and the patient to learn from each other about the pain and the response to the medication needs to be open. The information and the tests that are obtained and interpretation of those results lead the physician to the medication class that's going to be used. More often, more than one class of medication will be used to interrupt that pain signal and the brain's interpretation of pain. Certainly, sometimes the cause of the pain can be found, treated, and then the pain goes away. But for our purposes, we're talking about both things needed to be treated at the same time. So in summary, pain is our friend at first anyway, because pain is telling us that something is wrong and needs our attention right away. Pricking your finger or getting a burn tells you to move your hand quickly and get it to safety. But other pains are not so clear and not so direct. So getting help from your physician is important. Pain needs to be evaluated and determine the cause of that discomfort so proper treatment can be implemented. Once we've determined the cause of the pain, we need not to abandon our aggressive treatment of the pain, but now we have both of those things to treat, the pain and the cause of the pain. Treating pain is very complex, and we'll have other videos on the channel about different types of pain and how those are treated. Please keep a journal about your pain and share the information from your journal with your physician. That's really important for us to have that information. Follow the doctor's instructions about how to take the medication, and then keep us informed about what's happening with the pain as well as when you take that medication. Pain is no longer our friend when we know the cause and we're addressing that, but the pain continues. If you're playing professional football and you get hurt because of all the collisions that you've endured and pain is telling you to get off the field until you're healed, then pain is helping you. It's helping you know that you're in trouble. But if you're trying to live a more typical life and you can't work or eat or sleep because of pain, and we know the cause, pain is no longer your friend. For patients with cancer, COPD, heart disease, liver or kidney insufficiency or vascular disease, maybe damage from diabetes, these patients know the cause of their pain, and pain is just an anchor pulling their mood down and limiting their joy. Keeping your appointments with your primary doctor cannot be missed. They might want to involve a palliative team to assess with pain management and address the concept of total pain, which encompasses the suffering that comes with all that burden from the pain and limiting your life experiences. The person may have physical pain, and it affects their social life, their spirituality, and there are certainly psychological aspects from those pain effects. This is the first of several videos we're going to have about pain. If you have a topic that you would like to discuss, or if you've got a question, please drop it in a comment below. Thank you for your time. I appreciate you staying with me this far. You deserve a cookie. Thank you for being here. Bye now.